Welcome everybody. I think we'll get going. It is 3 minutes past. I'd like to welcome to Medical Forum, this will be a very interesting medical forum where we hear some of the changes that are occurring in our health system. And so it's my pleasure to introduce three people. First of all, Stuart Barson, who's been supporting the chronic disease management part of the Southern Health Alliance. Will be talking, followed by Wendy Findlay, who's the nursing director for WellSouth, and finishing with John Edmonds, who's actually a cardiologist, but interested in chronic conditions, and talking third, and then we hope to have time for some open discussion. So welcome to Medical Forum. Stuart, you ready to start off? Thank you.
Thanks, Barry. First I want to acknowledge the other members of the Long-Term Condition Network who have been part of a journey over the last few years and who've all contributed to what you're going to see today, Barry included. So thanks, guys, for coming. We really appreciate it. So some of you will remember that last year we talked about the long-term conditions program and set out what we were hoping to do. And this year's an update of where we've got, and in particular from John later about what it really means for people working more in the secondary and community and allied health. So I'm just going to briefly sort of go over the why. So the program is provisionally at the moment called Do the Right Thing, and we're definitely looking for a better name. So if anyone can come up with a better name than Do the Right Thing, please sing out, because it's starting to embed itself. What we're going to go through today just quickly is look at why, recap why we've done Do the Right Thing, give you some feedback from the general practices that we've been working with. We've started working with 5 general practices to test the model of care. And then look at again or John's going to look at the implications for secondary care. And I think it's probably worth pointing out here that the kaupapa really of the whole program is around standardisation, self-management, coordination, and particularly communication between all parts of the system. So I've lifted this from, some of you will recognise the primary and community strategy document that Ernst & Young have been consulting on, and of course lifted it with their permission, but we're not doing anything that no one else is thinking about around the rest of the world, or indeed in the rest of New Zealand, around stratification, multidisciplinary teams, and working much more with the community. This is also, of course, lifted from Ernst & Young's consultation document, and it just sort of shows the kind of things that need to be done in the system to create the kind of change that we're working towards. And their ticks and crosses indicate what's happening and what's not happening in our district. And I think what you'll hopefully see today with long-term conditions is that there's a number of extra ticks that we've been involved in. So Wendy is going to take over from here. Thanks.
Is it working?
It will.
Oh, is that working? Yep. Okay. Have you got the clicker?
You need that.
Yeah, thanks. Okay, so hi everyone. I'm Director of Nursing at WellSouth, as Barry said, and I'm also the chair of the Long-Term Conditions Network, which has been a huge piece of work that we've pulled together over quite a long period of time. And we suddenly feel like we're finally getting there. We're just really starting to see all of these pieces of the puzzle come together into what we're talking about today. So please do feel free to ask some questions. I'm sure you'll have lots of questions. We've still got questions, and part of what we're doing is user testing it in our practices to make sure we're getting some of the questions answered as we go along the process. So this is the picture that we had when we started looking at this. We've got a Care Plus, which for some of you who work in general practice, that's the long-term conditions management model that is currently in general practice. And there's about a $4 million spend on that program for each year. And when we delved into that, it was kind of really ad hocly done. It was done really well in some practices, not so well in others, and then there was kind of a group that did a average kind of job at managing patients with long-term conditions. And we've got no kind of measurable outcomes. So we don't know what the input into general practice is, what's going to happen, and what the outcomes for the patient is at the end of it. So this is our new approach. Certainly general practice-led management of long-term conditions. That was kind of the mantra of the network when we first started, was that people with long-term conditions are best supported in primary care and close to home. with support of obviously the secondary care team, but the base of the management of long-term conditions needs to happen in the community. Our program includes frail elderly, mental health, as well as long-term conditions. So we've tried to take quite a holistic approach rather than siloing it off to diabetes, respiratory, cardiovascular. It's looking at all long-term conditions, because generally when a patient comes to general practice, they come with everything. They don't just come with their diabetes. We're wanting to build on patient self-management and improving health literacy. And we're really wanting to support general practice with a team of people around them. So not just relying on the practice nurse and the GP and general practice to be able to support these patients, but looking at multidisciplinary teams in the community. And how? We've got standardised packages of care. We've done some risk stratification, which we'll talk about a little bit in a minute, and some standard funding that supports the different levels of packages of care in the community. Hope that's making sense. Yeah. So this is the new approach. All the patients that are currently on Care Plus program will go through a comprehensive health assessment on the WellSouth portal. So that's taken quite a bit of development. It was one of the largest IT projects that our IT developer has put through the portal. And at the end of that, when the patient goes through that portal, they are stratified into a different level of package of care. So package 3 is the most complex patient, down to a 0 who is a kind of not really requiring any kind of extra added intervention than they would normally get in their general practice. We have funding linked to each level and a standard package of care for each level as well. So a person at level 3, you would know if you were dealing with them in the hospital and they were at a level 3 that they would have an advanced care plan. They would hopefully have had a conversation around advanced care plan, have an acute care plan, a personalised care plan, and they will have had their comprehensive health assessment done. And the added thing for the package 3 is that multidisciplinary team meeting, which we're hoping will be across sector. And so how we're going to do that, we're wanting to really get some feedback around what would work for clinicians in the hospital, particularly nurse specialist roles and SMOs. So this is our stratification, which I'm sure those of you who had the last meeting will have seen. And it's no different than any other kind of stratification that is happening around the country. Does that make sense? Yep. So what's been done so far? We had an extensive consultation process. We visited all around the district. The group of us went round and talked to general practice. We've talked to respiratory nurses. We've talked here at the forum last year about receiving consultation and feedback on this model. And then we've gone through and developed it. And so we've got the development of the tools, which I talked about, the comprehensive health assessment, the risk prediction tool. So every patient over 45 has been gone through a risk prediction analysis tool. So we have that for each of the practices. And obviously the personalised care plan, the acute care plan and the advanced care planning are all kind of in various different stages of development. And we're doing those tools in Health One so they are viewable across the district and across the system. And the Flinders Partners in Health self-assessment, we've got Flinders here from Australia training a group of nurses who will roll out that train the trainer to practice nurses and GPs into the future. So they're in their training right today. They've got 2 days. We're trying to do this work not in isolation, so trying to build on what we've got, our thinking and what we're trying to develop through our acute demand management program with patients with COPD. We've tried to integrate it with what we've already got going at WellSouth with our long-term conditions team and our Desmond education, self-management education for patients with diabetes. So just trying to build on what's already happening in primary care for the management of long-term conditions and then trying to fill the gaps. And you'll see there that we're testing in 5 different sites. Those sites are across the district, so we've got a practice in Wanaka, one in Alex, one in Invercargill and 2 in Dunedin who are user testing our tools at the moment and are putting patients through the portal. So this is what the risk stratification tool looks like. So this gives us details for every practice around the patients. Obviously, I need to use this pointery thing. Is it showing up? Yeah, so on this side here is the NHI. So the practice will see the NHIs of those patients and can start to look through who they actually are and what their issues are at the practice, and start to put those patients through the comprehensive health assessment. And it also gives us the breakdown here of those that come up as very high, those that come up as high, and those that are low, and also who's already registered on Care Plus within that group. So it gives us quite a bit of information that we haven't had before about our patient groups. Now, I've only done a couple of screenshots of the comprehensive health assessment, but this is the tool that we've put in. This is what our portal looks like that the practices see. And so this is kind of the general page, and every portal starts off with this patient and provider, and then these boxes across the top change depending on the portal. And on this one here, for the comprehensive health assessment, if someone is actually over 65, then another box of a falls prevention and assessment box pops up there as well. So that's just a quick view of it, and each of those drop-down boxes have areas that the nurse or the GP can put in there, information they can put in, and then cover some activities of daily living, medication, and in each of the boxes, God, I'm not used to this tool, here with action, they can do referral to for the medications to a clinical pharmacist, or for a clinical pharmacist review, or back to the GP if the nurse is doing it for a review of medication. That looks at their sort of activities and what they've got, supports that they've got at home. And in this screen here, you can see that we're also trying to include the intra-eye assessments for those patients who've had an intra-eye assessment to make sure that we've got a complete picture for general practice, and we're looking at those inter-eye to try and alleviate patients having to do an assessment after assessment after assessment. And then this is what it comes out with. So that's not all of the comprehensive health assessment. I've just done kind of a couple of screenshot pages just to give you a taster, but certainly not the whole thing. And when they've done that comprehensive health assessment, Minnie Mouse, patient here, has come out with a level 3 stratification of, but on the Flinders scale with a high self-management capacity. So putting the Flinders tool in kind of indicates to the nurse or the GP who's doing this what that patient's level of self-management is. And then some of the actions that they've done as part of this assessment. And then this is where the care plans are on Health Connect South. So we're just about to get access to the acute care plan. We're still waiting on the advanced care plan and still negotiating around the personalised care plan. But we really don't want to develop a care plan out of a system view, because there's no point having a care plan that started in primary care and, you know, respiratory nurse specialists can't see it when they come into hospital, or the physician can't see it when they're in hospital. And the same if it started in hospital, the practice nurse and the GP need to be able to see it. What does this mean for patients? So I just kind of given a little bit of a case example of what it would have kind of happened for Mrs. Smith under the old program, and what we hope will happen for Mrs. Smith under the new whatever it's going to be called, long-term conditions program. We've got a couple of our user testing sites have got a bit of a challenge on at the moment is to rename it. They really don't like do the right thing. So the challenge back to them was, okay, let's find another name for it. And so they're busy beavering away trying to work out a new name, and we've got a few suggestions coming in. So one of them is Be WellSouth. So there's lots of discussion about what people like around that. they get a free lunch if they can get the right name, so might give them a bit of incentive. So that's hopefully what we're hoping it'll look like. And it's your turn.
Great. Thank you. My job is to try and persuade certainly the hospital clinicians here that this is not just management speak. This is not Ernst & Young fairy dust being sprinkled down on us, but actually that this has a very real significance. And the significance is, as you know, real because it is a really very real problem. We are going to be overwhelmed by patients unless we make some changes. This is data, you'll all have seen the Sapere data, I'm sure. Top left is cardiology, bottom right is rehab. And it's just exponentially going up. The numbers are coming into hospital are going up. Length of stay, bed days are going up. And we need to make changes. And these are the predictions from Sapere if we can make some reasonably sensible adjustments to how we manage our patients. The current work, as you've just heard, is predominantly around risk stratification, and that's going on around the world. That's from Cheshire, America, Australia, and that's our iteration of it. Lots and lots of versions around the world. As hospital clinicians, we need to be aware that this will make a bit of difference, but the numbers are stacked against us. The admissions are all going to come from the lower levels because that's where all the patients are. Yes, the high-level patients are the ones who are at most risk, and they are, in that group, highly likely to be readmitted. But actually, from our workload, it's the bulk of the majority of the main lot who will come in. Also, we need to be aware that the conditions which we're targeting need to be ones that can be managed in the community. There's the idea of the ambulatory sensitive conditions. This is a list from the NHS. There's a New Zealand list, which I didn't put up here because it was not quite so pretty. It was much longer and spread out, but essentially it's a very similar list of things that we think we can arrange, you know, working with primary and secondary care, we can manage them in the community rather than in a hospital bed. I have a slight issue with perforated ulcer being managed in the community, but I think these things can all be debated, can't they? How are we going to do this? Now, the big headline here is none of this is rocket science. There's no one going to get a Nobel Prize out of this. But we just need to up our game and do two things better predominantly. One is communication, and secondary is to get better trust between the secondary care and primary care. On the communication front, we've got care plans. We've mentioned them already, but it's something which needs to be significantly expanded. We need the chronic care plans to look for the chronic care and how we're going to manage someone over the years, the advanced care planning to work when we're talking about their death. But we also need the acute care plans, which are slightly different. What are you going to do when that patient becomes acutely unwell, acutely dyspneic, acute abdominal pain? What are you going to do? And that data needs to be available to us in secondary care, but it's also got to be available to everyone in the community, and that includes St John's. And I'm aware just now there are some problems with St John's, that they are not able to get the acute care plans which have been written so far. So unfortunately, their reaction is to scoop the patient up and bring them to the emergency department. But if we had proper acute care plans visible for everyone, we could avoid that. I'm a big fan of the idea of virtual meetings, as secondary care getting together with primary care, doing virtual clinics. We don't need to see a patient with long-term conditions. We don't need to eyeball that patient, providing they're being seen regularly by the nursing staff and the GPs. As a secondary care physician, I don't need to see them, but I may well need to be able to give advice and help manage that patient. So a lot of these things can be done virtually, and my workload can be moved from sitting in a clinic in Dunedin into the community, going to work with the GPs, looking at the virtual patients. The other bit of discharge, of communication, is the whole discharging from hospital. We know currently that our discharge summaries are more often than not pretty poor, and we can do an awful lot better. And one of the ways of doing that is the idea of discharge bundles, of making sure it's essentially just a checklist. Have we done everything? Have we documented everything? And are we making sure that information is going with the patient into the community? With communication, with time, with effort comes trust. And we in secondary care need to trust our colleagues in the community that they will pick up this patient. They will go home and they will be seen within X weeks by someone who we understand and we know and we work with. And we know there's a consistency of response from that. Equally so, the GPs and the community teams need to have consistency of response from us, that if they ask a question, either a written letter or an email or whatever communication method we have, they know they will get an answer well thought out reasonably soon. And part of the whole virtual meetings and communication is to increase capability in primary care. Make sure that I don't worry that the patients are going to be left languishing. They're going to be undermanaged. That's always one of the concerns. And if you look at a lot of the data from the heart failure trials, the hypertension trials, patients are never quite as aggressively managed in the community. And there's a number of reasons behind that. And we need to go and work with the guys in primary care and make sure that capability is increased. And of course, as part of trust, we need to trust the patient. We need to educate the patient, make sure they're aware of what they should be doing and shouldn't be doing. And we do need to trust them. We need to trust them that they won't go home and drink a whole lot of fluid and eat a whole lot of salt if they're on diuretics. That's just part of the education process. We've already got a good start on this, and I'm delighted to see both Tim and Jack here with us. There's a great start made on the COPD front of getting the care packages, the discharge bundles, the care packages, and beginning to align a lot of these things together. Now, if other services could copy what these guys are doing, I think we'd make a massive step forward, because it really is a very good start. The final thing to bear in mind, though, is that this is all part of a PDSA cycle, and we need to look at what we're doing, we need to review what we're doing, but we also need to be patient about it. One of the concerns I have with a lot of the data that you see is that it's 3 months, 6 months, 12 months data. And oddly enough, in rolling these programs out at 12 months, it's not made much difference. The data on the right as you look at it is an Australian study beautifully put together in heart failure, which showed that having done a very aggressive, well put together program, it made matters worse. It was more expensive and there are more hospitalizations. My take on that is actually 12 months is just far too premature to be making that call. That this is part of a long-term project that we need to just alter the way we work to move care from secondary into primary, and importantly, move carers from secondary into primary with those patients. That's all I've got. You got anything to add, chaps?
Great.
Right.